BPC-157, TB500, GHK-Copper, and Retatrutide. These are the topics that we're going to be discussing today amongst intermittent fasting and even a 5-day fast. So lots of interesting topics. Stay tuned. So I wanted to welcome everybody to the Soffer Longevity Podcast. Today, we're going to talk about some very interesting things that kind of combine the two things, traditional medicine and functional medicine or longevity medicine. And we're going to discuss topics like peptides and where they actually might start coming into a traditional medical practice and where they may not. We're going to discuss this just like two doctors that get to discuss in kind of a little grand rounds, or as we discuss at the lounge, and you get to be a part of it. We encourage you to subscribe below, ask questions that we will get to as you become followers of our podcast. And we really hope to lighten the conversation so everybody gets to understand what's going on in this longevity world. In particular, this week's episode is about peptides. So with that, let me introduce Dr. Safa Maklad. She is a board-certified family practitioner that actually has tremendous training in functional medicine and actually multiple board certifications in a variety of medicine. That gives her a unique capacity to sort of straddle both traditional and longevity medicine, and I'm blessed to also call her my friend and personal physician. So how are you, and welcome.
I'm doing well. Thank you for having me again.
Good. Great. It is my pleasure. So let's talk a little bit today about one of the most important things that we're seeing swirling around the internet. We're getting questions almost every day from patients, peptides.
Yes.
And what does that mean, and what do you think about them in your practice of medicine?
Okay. Well, I think maybe we should just talk first about what a peptide is. So it's a short chain of amino acids, and there are multiple medications that are based on peptides. The first one, I guess, that was approved was insulin. So peptides have been around for a long time, and we are just discovering more and more as the days go by. So there's lots and lots of different types of peptides. Probably the most famous one at this point in time is probably Ozempic / Wegovy as the GLP-1.
Sure. So those are peptides that got to the pharmaceutical companies, and of course, there's no shortage of information about that, both on regular television, online, whatever. But what is a little confusing is the ones that have not gotten to the big pharma yet. And the most common one I get asked about is this BPC-157. So tell me what you know about it, what you think about it.
So BPC-157 is the body protective compound, and they named it, with that 157 just because that was its number in the different peptides that they were researching. It's found in gastric juice, so that's where they isolated it from. And they've been researching on how its repair properties are. So it causes angiogenesis, or it helps you make new blood vessels. So that's kind of its repair mechanism. They've noticed in animal models that it can help, tendons, ligaments, things that don't have a very good blood supply. And they've noticed that it's been repairing some of these injuries, like they've actually cut the Achilles tendon of a rat and it healed with the BPC-157.
Yeah.
So now they're trying to move that to human studies to see, how is it helping with healing, so / for ligament tendon injuries, or even for the GI tract in patients with inflammatory bowel disease.
Yeah. I've heard both of those. I know that those studies are in early phases. However, I've not seen, and I don't think there are any published human studies, but there are a lot of animal studies. And then there's all this information from the sort of social media and the influencers that are anecdotal. Lots of people saying, I had an arm injury and I was going to have surgery, and I was able to avoid surgery by having either a specific injection or a systemic injection. I think it's more specific to the
To
area.
yes. So it can be taken by injection, subcutaneous injection, or orally, but usually when you're using it orally, it's for the GI tract.
Ah, I see. So it's probably unlikely to take it orally and then get it to go to your shoulder.
Yeah, probably not. No. There is a human study with about 70 patients at this point. It's not published yet, but at least it's there. They're starting to actually do studies on humans.
Yeah. And we know as scientists, you and I know how that goes. So you do a study that shows something has to then be reproduced so that it's scientific method, meaning it reproduced, in another place. So there's less bias issues. And then you get into dosing, right?
Yes.
So like you and I have been, investigators on studies and know that like there's a lot of pharmacokinetics or understanding what dose works in a rat, what dose works in a human, what dose interacts, and what dose may cause more side effects, sort of tips the scale of more side effects than benefits.
Yes.
So I don't know that we're anywhere near that.
No, not at this point.
And the idea of vascularization, so the body is so, you have to be so careful. And vascularization, as a cardiovascular physician my whole career, it's all been about restoring blood flow. Except there's one place you don't want blood flow, and that's in tumors.
Yes.
So
you don't want to help it along.
don't want to give them. So I have not heard of any safety issues around BPC-157, causing maybe increased tumors, like we've heard with some of the growth hormone.
Yes.
Stories in the past, and then subsequent studies that make it a little more concerning. But BPC-157 is thought to increase vascularization. It's also thought to modulate immunity and some other things. But the safety profile so far, I haven't heard on the anecdotal side or in the animal models any concern, right?
Yes. So far, nothing. It's actually been pretty safe. No, nothing that they've seen. So.
And sometimes it takes a lot of people. Sometimes you have a small study or even a medium-sized study, and then it takes millions of people to use it to figure out, oh, this is a problem.
Yes. Yeah.
Which is why I tend to wait to prescribe medications until there's also a period of time where you can have millions of people have taken it to know, that it's okay. Because sometimes you've seen, as we've been practicing long enough to see recalls or cessations where things get taken off of the market. But BPC-157 looks very promising.
Yes.
And it's hard for us to tell our patients no to that. So how do you handle it right now? How do you what are you going to do for the future when these become, and tell us about how they're going to become legally made in the United States?
So technically right now they're not allowed to be compounded. In July there's supposed to be a meeting that they are going to decide on which of the peptides will be allowed to be compounded by the compounding pharmacies. So everybody's waiting for this meeting to see the list that hopefully gets approved. BPC-157 is on that list. But then once that is done and it hopefully approved, then a prescription can be sent to the compounding pharmacy, and that's how it's made for the patient. Compared to right now, there's a lot of sites on the internet that sell BPC-157, but if you look at the label, it says for research use only, which technically are not supposed to use in a human.
So let's take a little diversion just to explain to everybody. A compounding pharmacy is different from, say, a Eli Lilly major pharmaceutical company because they have less regulations. They still have regulations. It's, I think, A and B. So they have basic regulations, meaning that what you get in a bottle is probably what they're saying.
Yes.
Doesn't necessarily mean that whatever it is, let's say BPC-157 is good for every tear that you have in your shoulder, but at least what's in the bottle is probably safe and not infected or it's been sterile, and that it's that kind of information is much more comforting than what people are seeing out there right now, which could be coming from another country. It could be Not what's in the bottle is said is in the bottle,
Yeah,
right?
because nobody regulates that. So it's very hard to tell what you're getting in the bottle. But at least from the compounding pharmacy, you're kind of a little bit more, confident that what you're getting in that vial is what you're supposed to be getting. So with the compounding pharmacies, it's not necessarily that that medication is FDA approved. It's just that compounding pharmacy is allowed to compound it.
So let's say now we're in July and it's been approved by the FDA, and you get your BPC-157. You have to inject it most likely.
Subcutaneous.
Near, I'm assuming, the area of concern.
Yes, you try to get as close as possible. Sometimes it's not, you don't want to inject in like sensitive areas, but you try to just get to as close to the area of injury as possible.
Seems to me like that's probably best done in a doctor's office, because you're not talking about an auto injector. You're
pulling it up from the vial, and they have to make sure that the dose is correct. So so usually like with a first injection, you want to make sure that the patient's able to do it correctly.
Right. You don't want to inject in a joint.
Or in a blood vessel, or
a lot of problems. Yeah. So. Well, it's exciting that this is coming. It's exciting that people are now given the choice to basically be study subjects on themselves if they choose so. I mean, that's just where we are in this country, that you're given the choice to take something that is that you're a little unclear with, but maybe it's better than your alternative, or maybe your alternatives haven't worked. I got to tell you, my experience with compounding pharmacy was when the GLP-1s, the first Ozempics came out. And people were on it, and they were flourishing, and they had cured their diabetes or their high blood pressure. And then they ran dry. The companies didn't have enough.
Yes.
Which is, I think, why compounding pharmacies were originally, or at least what they're most commonly used for, should be used for, is that when a pharmaceutical is available, but the manufacturer can't keep up, because we're a big country, then a compounding pharmacy can kind of make a safe alternative. So we were giving the semaglutide early on when there were shortages.
Yes.
And that felt great, and people did great, and they got it, for even a fraction of the cost. So they were happy, like kind of everybody was happy.
Yes.
But as there is no shortage of those, medications, then it becomes a little trickier in terms of, is it even legal for a compounding pharmacy to do it? I know they have a list, right?
They do. I mean, it's on the bulk list that they're allowed to compound. They just have to, because of issues with the patents. That's where it's getting a little iffy because of the patent that the pharmaceutical companies have.
Yeah. I mean, I understand that kind of it takes millions, if not billions of dollars to make a drug, and then they have to kind of make it back. But there's also like a sort of excessive costs that need to be sort of either regulated or brought down, which I think they successfully have done with the Ozempics of the world. They're now a fraction of what they were.
They're definitely better pricing from where they started.
Yeah, they were a few $1,000s a month. Now they're like a few hundred or less to start. So that's exciting for folks. I guess, that kind of delivery system in a country this large that has an obesity epidemic this big, it sounds like that's getting figured out.
The other thing I want to say about the compounding pharmacy is that they also let you adjust the dose. So that's also the good thing, is that you can actually dial in the dose for these patients. So like with the Zepbound, or the Mounjaro, you have that auto injector pen, so you get one dose. So that's the other.
I would agree with you on that. That probably the most difficult thing that we have as physicians is one dose does not fit all, and we take things that are studied on thousands of people, and then you have a personal situation with Joe Smith from the contractor from down the road that is a very specific type of a person that has specific DNA and lifestyle choices, and then their dose of 20 milligrams may not work where it would work great for his Aunt Millie. So adjusting the dose is like super
Yes.
personalized medicine, and the patients have to and are starting to play a bigger role in understanding what that means for us and for us to understand how to adjust that dose, both to get the best effect and to avoid most of the side effects.
Yes.
Back to that pharmacokinetics thing, which was a short class for us in medical school, but maybe one of the most important ones, because you got to find that right spot for each patient, and that's where we're getting a good intake and really understanding what the goals are. Let's move on to another peptide that you mentioned that's getting a lot of sort of information circling the internet. Let's talk about, was it TB-500?
Yes, so TB-500, they use it a lot actually with the BPC-157, so they kind of help each other. So it's actually a fraction of a different peptide called thymosin beta. So that's with the TB-500. So it's just a smaller fraction. It helps with wound healing. It just kind of helps bring in the troops if you want to, with inflammation and stuff. So it helps decrease inflammation, helps with wound healing. So a lot of people will use it with the BPC-157.
Part of that stacking thing that they say. So not only do we don't know about one medication, but now we're giving two medications.
Yes, that's what they call the Wolverine Stack. I think that's what they...
The Wolverine Stack, I heard that. I think it was Joe Rogan.
Yeah, so I think that's what they decided to name it.
So another peptide, is that one going to be released as well?
Possibly, yes. It's on that. Either the TB-500 or the thymosin beta one of the two.
So if that comes out, it's likely to be used in combination with the BPC-157.
Yes.
So we'll get requests for that. And again, I'm assuming that these compound pharmacies already have some experience, and by then will be very experienced in delivering a quality or
and figuring out the different dosages. And I think that will be
right.
That will be the biggest thing, is just trying to figure out the correct dose for this.
Do you know of any studies that they're doing on humans to get that sort of better understood, or is that behind BPC-157?
I think that one is behind BPC-157, but you have a lot of case reports, so that's
Yeah. What about copper? Like I've gotten a lot of questions about copper, and wanted to hear your thoughts about that. About the peptide, the
GHK-Copper, yes. Yeah. So that actually helps your cells kind of move. It helps the actin in the cell, so it helps them mobilize. So if you have a wound or you're trying to help something heal, it just helps it move better. So with different types of wounds, and the interesting thing about that one is that it can be used topically. So right now you can buy it topically, no problem. We don't. It's not regulated. Well, it's not like.
Was shown right in the dermatologic world to help with some sort of skin.
Yeah. So they call the anti-aging. Yeah. So it helps with what the skin.
Well, you have terrific skin. Do you use it?
I do not at this point, but but definitely looking into it.
Yeah. So it's our dermatologist prescribe?
Yes. Topically. Yes.
And typically topically, it's kind of fun to say, typically topically, you don't see the skin as a kind of a decent barrier for systemic absorption. So most of the time when you do something on the skin, it doesn't necessarily go to that particular area systemically. So it doesn't get into the body as well.
So it's working just locally.
There's a barrier. So really you are just giving it to that kind of a layer.
Then the other way is to inject it, and that is why they use it in trying to help wounds heal. They'll do all three of those together, actually, to help wounds heal a little faster.
So are they giving this GHK-Copper for other reasons systemically? So let me just organize in my mind. So dermatologically, they're giving it for beauty, for skin, for sort of anti-aging, or wrinkles, or what is it?
Wrinkles, just making the skin look better.
And that is given by dermatologists commonly as like a supplement, or is it a prescription?
As they do write as a prescription, because sometimes they combine it with other stuff.
I see. And the new thing is that peptide can be given intramuscularly or subcutaneously, can be given as a shot, and then it's thought to maybe work with these other two as an anti-inflammatory or a healing mechanism. But we don't know what it does as side effects. We don't know how the combination, because that's the problem. And I'll let everybody out there know. You as my longevity physician, we did tremendous testing, which we discussed in one of the previous episodes. But one of the things, when you gave me my supplements, which were given for things I was deficient in, which was many of which were a surprise to me, even vitamin D, as you can see, I'm in the sun a lot, and I eat a good amount. So, but no, I was deficient in vitamin D. But then I got my supplements. So I decided the best thing for me was to take one supplement at a time, to make sure that if I had a problem, I knew which one it was.
Yes.
Do you recommend that kind of method?
Yes, because again, you don't know which one is causing the problem. But then on the flip side, they say that they work together. So that's kind of that balance.
Saying that. Right. It's funny. I give prescriptions all the time on the cardiovascular side. I don't like those pills that come together for the first time. What I typically do is give, maybe it's a statin and it'll go with another medication. I give them separately. Then, if I find it's working and there's no side effects, then I give it in a compliance-friendly way, which means one pill that can go together. I think the same thing should go for supplements. You kind of try one, make sure it works okay. Then add the next, make sure you're not having any symptoms.
Yes. It just makes it easier, because then if you do encounter a problem, then you know kind of who to blame.
I think that's a wise choice, particularly after you've gone through testing. And so, again, as my personal physician, and what I want the viewers to understand is that it feels best to me to take supplements that we have something to measure. So whether the measure is something like your glucose numbers or something a little more intricate
like
your ferritin level or your homocysteine level, these levels that we know that deficiencies aren't good. And even if you're in a green zone, but you want to be better on the green zone, so meaning you have a normal, but you want to be better on the normal range, because being worse on the normal range could lead, you don't want to only take it when you are deficient.
Exactly, yes.
So it goes back to that trending and then graphing that trend, which we, want to also always mention, having a medical record system that helps put all of this together and kind of graph it over time. We happen to use, we have obviously a sponsor that we've clarified at the beginning of every show, but Longevity AI does a great job of sort of graphing the information over time, so that we kind of can know how our treatments affect what our diagnosis is, or what our laboratory values are.
Yes, yeah. It's that is the most helpful, is to know. So you're not looking at points in time. You are looking over a good amount of data. You can see all the data points, so you can tell if they're getting better or worse. What you're doing, is it helping? That's.
I'm very, very happy to have had you go through my stuff, give me my book of You, I think it's called, and then I have an app that helps me with those trends. So it reminds me not only to take the supplements, but to periodically check them and make sure that if it's deficient, it's no longer deficient. Not something that we know about with the peptides, because we don't have anything objective with them. And as this segment today is really about the peptides, it'll be lovely to see that we can see something that says, oh, you are a BPC 157 deficient. You're BPC 156.
Yes.
We need to get you to BPC 157. And so to do that, we're not there yet. Hopefully, there will be some things that we can check. Let's talk about an up and coming peptide,
Retatrutide. Yes, it's hard to say.
which is under investigation in late clinical trials with Eli Lilly, and will be coming out, they think, this year. But it is the new triple agonist, as I understand it, for the GLP-1s. And supposedly the weight loss is amazing, and there's muscle sparing. So somehow, because of the glucagon, it seems to not have some of the muscle sparing issues that we're seeing with the Ozempic class or the tirzepatide class, the Mounjaro class of drugs. Tell me what you know about that or what you're thinking.
So, the amount of weight loss that the patients are having is tremendous. It's, the most out of all these medications. The most important part is that it's muscle sparing. So somehow that glucagon that's in there is helping protect the muscles. And that's I guess all we really know at this point.
Well, imagine, all the listeners out there that are like, wait a second, so I can lose weight and gain muscle or keep muscle, or even gain muscle. There's one that I think is also got an agonist on the muscle side, so it actually can help to develop muscle. So that it's going to be very difficult for us as clinicians to be able to tell a patient that has heard about this, no.
Yes.
Now, right now it's an easy no because we know it's not being even made legally.
Yes.
Right? The compounding pharmacies have been making this drug, but the issue of legality gets a little wonky because I think they can get it, but it says for research purposes. And you want it to say, listen, you can take this for weight loss because that means there's a high safety profile. So that's going to be a big conversation this year. We're going to probably have special shows just on it because it's so compelling at what it can do. The human data is now so interesting, the stuff that we've been getting to see. Major companies are around it. And, I think the average patient's like, listen, I want this. I want to get it FDA approved. I also want to get it affordably.
Yes. Yeah.
And we know it's probably not going to be that affordable to begin with.
Beginning.
And insurance companies are unlikely to cover it early on because they like to say, well, it's experimental for the first, few years. So we're going to be dealing with this onslaught.
Yes.
We already are. I mean, I already know people, I'm taking Retta, I'm taking Retta. Where did you get your Retta? And a little uncomfortable with it. But I haven't personally seen any terrible effects. It doesn't mean it's not there, and I'm definitely not giving this as advice to anybody, but it's coming, and that's why we have this program, so you and I can talk about what we're seeing in the clinic, what we're hearing, around the town and the gyms and everywhere that we kind of
usually the gyms.
So, well, I think we've covered quite a few topics. I wanted to, is there anything new on the peptide world or in general regarding longevity that was interesting to you or that you're, considering on a personal level? Like intermittent fasting, I understand, is becoming a bigger and bigger thing.
Yes. So I'm actually doing a 5-day fast. So I'm on
Currently.
day number 2. Yes. And just to kind of reset everything. And so I definitely like fasting, intermittent fasting, whether it be short periods, longer periods. But I'll let you know how the 5 days go.
Wow. So I've heard a lot about the intermittent fast. I don't eat after 8 and I don't eat breakfast. That has been away from me for a while. I have diabetes in my family, and so I have avoided it. And it helps me with some weight control, and actually I feel good when I do it. Sometimes I don't. On vacation it gets too hard. Time changes, but for the large part, 95% of the time I do it, and it has been very useful for me. And when I wore my continuous glucose monitor, it showed that it was working out pretty well. But that's just a 16/8, a 16/8 situation versus a 5-day thing, which I heard a lot of data to suggest from some some of my colleagues who are deep into this nutritional part of the field that day 5 is actually you start to see a real benefit from things like senescent cells, so anti-aging cells that are, the autophagus cells that are out there, sort of cleaning up the.
Yep, because the body can focus on repair instead of trying to digest food.
And for some reason, it seems like day 5 is like this sort of.
You feel the best, usually at day 5.
Have you done this before?
Yes, I have. But this time I think it's just because it's day 2, so I'm like, this is a little hard.
Yeah.
You just have to get over the hump.
Is there like, there's a, one of my colleagues out at USC, a doctor by the name of Walter Longo, came up with a fast mimiking diet where he has these like sort of bars and soups that are very low calorie.
Low calorie, yeah.
And it's a little easier to get to the kind of that day 5. Are you doing that?
Yeah, so it's a modified, so it's not just water. It's very, very low calorie foods. So like bone broth, and that's about it.
That's what you're doing. Are you using them? That company? I forget the name. But
no, just kind of
yourself,
buying.
Got your stuff, and you're going to go low calorie and lots of water,
fluids,
water and electrolytes, I guess, with it.
Yes.
So it's nothing that we're recommending for everybody to do because you want to do it under the supervision of a physician.
Yes.
But it's I have heard good things about it. I don't.
Maybe you'll try it one time.
No. I don't know that I could. I love food. I don't know. It's like, it'd be hard for me to do a 5-day. It's easy for me. And you know what? I shouldn't say that because the truth of the matter is when I first heard about intermittent fasting before I wrote, our little book on it, I didn't think I could do it. And it has become very clear to me that not only do I feel better, I don't feel I can't not do it. So there is something that you go through, but a very interesting information on these kind of diets. If you really think about it, there are some cultures that require a lot of fasting in them. Sort of, you have Ramadan in Islam. You have lots of fasting days in Judaism and Catholicism and various other sects that use fasting, but they're kind of different. Like in Ramadan, for instance, I think you eat a lot at night.
Yeah.
So it's not like multi-day, and maybe not be low calorie because you're catching up at a particular time. Same thing with some of the other, Yom Kippur, things that you give up for Lent. So I don't know that they're really doing it scientifically, and this. Scientific approach, I really can't wait to hear. Maybe we can do a whole episode on
the different fasts.
Oh man, it'd be so cool. So our viewers get to see not only an expert, but a conversation. It's basically a lunchroom kind of conversation. Maybe you shouldn't say lunchroom.
I shouldn't say lunchroom.
Hey, a conversation between two doctors that are also hopefully listenable, people talking in lay terms about an experience that you're going to go through and how it, in this case, kind of cleans your system out, right?
Yes.
That is your
That's
goal.
the goal.
Well, that is very cool. So, well, I think we covered a bunch in terms of the peptides. I think that people, buyer beware. So as long as everyone understands that it looks like it's going to be after, was it 12 of them?
The list keeps changing. So we are at sometimes 14, sometimes 9. I'm not sure.
So a couple of handfuls of peptides that will be made available through compounding pharmacies without specific indication, so off-label prescriptions, which is a buyer beware situation. But sometimes a person's risk-benefit, particularly in consultation with a physician that has some experience with it, will get them to feel better and hopefully be better. And that's also a way that we're going to learn about the side effect profile because let's face it, either it's anecdotal through community use or it's through a regulated trial. That's how you find out if there are issues. So far, I haven't heard of too many on these. That's maybe how they're deciding which of the hundreds of peptides that are out there, the dozen or so that will be released. And so it's exciting. It's medicine 3.0. It's going to awaken us to these alternatives we have, like compounding pharmacies and so forth. And then people like us will talk about it and see which patients are doing better and which maybe not as useful for
Not as
it.
promising.
And then hopefully we'll have the data aggregate in our centers, in our software capacity, so we'll be able to be more intelligent with every podcast that we do and say, hey, we had this happen or I had this happen. And, hopefully it's interesting to people and they'll get the information from here and from other sources and bring it back to their personal physicians and say, hey, we heard this on the sort of Soffer Longevity and Dr. Maklad, did the fast herself and she felt great and look what it did to these numbers. So hopefully that's what everyone will gain
from listening
out of this. And I'm, again, so grateful for you taking the time to talk to us and giving us your perspective as always, and look forward to
our next conversation.
Another segment. So thank you so much. And thank you everyone for listening. And remember, subscribe below, and we'll see you next time on Soffer Longevity.